Hi there people. We're going to talk about NNTs, tender points and trigger points, clear up some myths, what they mean, hopefully get rid of using that word not. We'll start talking about fibrotic areas and these words with tender and trigger points. On here, it's probably the most utilised technique that we do out there, but because lots of people have these we keep using this word not, feels like a firm bit of clay. Your fingers and thumbs kind of meet a bit of resistance, and probably at the moment you've been doing some foam rolling or some thumb rolling, using different kind of bony landmarks to kind of get us around there, just to work that knot out. So we're just going to do a bit of a kind of recap. We've got some clinical aims, that therapeutic aims, the dimensions that we talked about in weekend 1 and the modes of loading, and then make sure we understand the difference between a tender and trigger point. Clinical aims are obviously a set of objectives are out there that relate to the individual, thinking about increasing people's improving their mobility, increasing their mobility and reducing their pain. We have therapeutic aims, so a set of objectives that kind of relate to health, i.e. we're kind of talking about physiological changes, psychological changes. So when we do any new technique when you're out there, whether it's a new massage technique or whether it's a new stretching thing you've seen on YouTube, use those clinical and therapeutic aims each time, and that should hopefully allow you to justify why you're doing it, what tissue are you working on, and what outcome you're trying to achieve. Dimensions we mentioned before, for weekend 1, day 2, it's a set of pathways which manual kind of therapy innovates to stimulate change, so whether it's a neurological change, so whether they're trying to reduce tone or reduce that kind of spasticity in that muscle, whether it's a physiological, so we're thinking about fluid movement, lymph and blood, whether we're thinking that it is a physical, so thinking about stretching tissue, and then we have our psychological, which is continually out through all of our treatments that we do. Modes of loading, we've mentioned some of them. We have directional forces that are imposed during manual therapy to stimulate change. So why do we do the techniques we do? As a good soft tissue therapist or sports massage therapist, we should be thinking about this all the time. So remember, we've got our clinical aims, so we're thinking about reducing pain, because that's why your people are coming to see you, because there's some discomfort. They might not be happy because of this discomfort that's occurring. We then need to think, as a soft tissue and a sports massage therapist, we need to think about getting that length back into that tissue and then increasing the strength. So always one of those things, when someone comes into clinic, you'll also be saying to they've got some neck pain, you'll be doing your postural assessments, you'll be ascertaining which muscles might be short and which ones might be causing the problem. Hopefully you'll then do your treatment, reduce some of that pain and increase some of that movement. Think about giving them some stretches to do regularly, because we know we want that length back in there, and then maybe think about adding some strength in once that tissue's at its normal length. So therapeutic aims, we're thinking about fluid dynamics, the reparative process, and the adaptive process. So how we as soft tissue therapists can affect this, and what happens during these phases. So when we talk about fluid dynamics, what do we do when we massage? We're moving fluid, we're moving blood, we're moving lymph, we're moving fresh, stale or stagnated fluid out of tissue, moving it back in. When tissue is not being moved, we get this adaptive process, so tissue starts shortening, we get fascia start shrinking, muscles start losing their length and their strength, tendons and ligaments all start receding. We as soft tissue therapists can obviously help that reparative process, so we think about the repair that's going on, think about the injury that's occurred, and how we can intervene and help our clients get back to day-to-day activities or their sporting as quickly as possible. So I mentioned before the modes and the dimensions that we work in. So we're thinking about the psychological, neurological, physical and physiological. We should, as good therapists, be challenging what technique we're doing. We may not want to bring all of them about, but we want to make sure that we're gaining some of them whenever we're doing our treatment, and especially when we're adopting a new technique. So up on the screen here we've mentioned this tension, we've got compression, we've got rotation, we've got bending, and then we've got shearing. So tension, that mode in which we work, we're thinking about elongation, extension, we've got longitudinal stretching, we've got traction. When these are all brought about to the tissue underneath, we get collagen aggregation, so collagen is laid down. It then increases in stiffness, but also increases in strength. So collagen can be our friend and also our foe. So we need to bear that in mind when we're doing certain techniques repeatedly, because what are we trying to change? Our technique that we use quite a bit, called compression, we're thinking about shortening and widening, and hopefully you should be asking, well, what are we trying to shorten and widen? It's the blood vessels that are underneath there, those lymph nodes. So it's moving fluid. A very effective technique, give you an example, would be cat paws. Compressing loading over there, and fluid flow would increase. Another way of remembering this, see this is your SpongeBob SquarePants. You give SpongeBob a squeeze, all the fluid goes out, you let go, and he reabsorbs the fluid. Rotation happens round at the joints, so we've got compression and we've got kind of articulation and progressive elongation round the joint. Bending, we then got this flexion extension if we take the knee joint, so then there's tension building up around the joint and compressing fluid inside the joint. We then get tissue elongation and compression, and then we've got some of that joint articulation going on as well. What we need to surmise, even though there's quite a few modes of loading there, is that most of techniques that are out there kind of will use tension and compression in combination. There's not normally one that's used on its own. It was just a brief recap of kind of what we should be doing as soft tissue therapists, because we're now going to start talking about a new technique. You may have had this done on yourselves, you may have tried playing around with it before today, but this is where we're going to go. So we've got tender points and trigger points. So by the end, we're going to know what they are, what causes them, how we locate them, how we can treat them, and how we can prevent them from reoccurring. So tender points are local areas of deep tenderness and increased resistance. Trigger points are where under pressure, a tender point refers to another area. So before we kind of move on, let's just recap that. You've been finding knots and these fibrotic areas underneath thumbs and fingers. If you've been putting some pressure on it and your clients have been saying, yes, I feel that locally, that is a tender point. If you give it a compression or a bit of a squeeze and it refers, we're talking about a trigger point. So they're two different things. So remember, this is not to be confused with trigger point therapy, something completely different. Tender points which do not refer pain are often to be considered latent or embryotic trigger points. So if we find a tender point and it's not referring, but we leave it alone, it has the potential to become a trigger point. Causes may be a number of stress factors resulting in altered tone in tissues. We've got postural imbalances, hypertonic muscles, ischemic effects, which have compressions on the nerves, and then we can get musculoskeletal injuries that can bring all these tender and trigger points about. So an increased tone leads to restriction in arterial supply, which will diminish oxygen and nutrients, increasing pain and increasing tone. A bit lengthy, but in the core of a trigger point lies a muscle spindle. So take your minds back to weekend 1, day 2, which is in trouble for some reason. A couple of them we've just mentioned on the previous slide. Visualize a spindle like a strand of a sweater. So it's a metabolic crisis takes place, which increases the temperature locally to that trigger point, shortens for a minute part of that muscle, so those sarcomeres, like a snag in a sweater, reduces the supply of oxygen and nutrients to that trigger point. So during this disturbed episode, an influx of calcium occurs and the muscle spindle does not have enough energy to pump out that calcium back outside the cell where it belongs. Thus, this vicious cycle is maintained and muscle spindle can't seem to loosen up the affected muscle and can't relax. Going back to the calcium, if you're not too sure where calcium fits into it, go back into some anatomy and physiology and look at your sliding filament theory, which is where calcium is pumped in but also has to be pumped back out. Otherwise we can get these states of trigger and tender points occurring. So how do we identify them? It's normally sharp and localized discomfort and pain, often referred. Movement restriction, we can get some muscle weakness, protective muscle hypertonicity, or there might be some spasm going on. Lowered skin resistance, so when you give it a palpate, it's not as squishy, it's not as pliable, you're meeting like almost like something firmer, and then we get changes in palpation with what we're feeling. So the number of treatments of tendon trigger points include coolant sprays, direct pressure, acupuncture, etc. But what we're going to be talking about now are neuromuscular techniques, so NMTs. What are NMTs? They are manual therapy techniques designed to influence or correct neuromuscular dysfunction, often displayed as a transient or permanent change in muscle tone. So some of your clients may be complaining of the muscle kind of tone coming and going. Sometimes it's there, sometimes it's not, or sometimes they complain of a permanent tone change. Techniques to be considered the most effective are gliding or stroking and compression. These techniques are used independently or in combination. NMTs are interpreted and applied differently according to both country and therapy, all generally agreed on the intended outcomes, so pretty much the same. So these aims of techniques use mechanical and a reflex stimuli to influence the neurological control over the musculoskeletal system. So when we start using new techniques as sports massage therapists, we need to think, what's it doing? Not using it because Wayne showed me, Tim showed me. We need to be justifying scientifically what's going on. So we've got compression causing ischemia. Ischemia meaning lack of blood, so remember that compression. So as we apply pressure, fluid is being squeezed out of that trigger point or tender point that's underneath. Pain mechanisms are releasing endorphin because this can be quite uncomfortable, so the body will release endorphins to deal with that. The stimulation of GTOs, because we will be holding for longer than 6 seconds, so we can't get away from that. And then the stimulation of peripheral nerves, and that's the nerve endings that lie very superficial in the skin. Whatever normalization and restoration of soft tissue we achieve, it is only significant if we use it to underlie the problem that is also addressed. So we need to think about posture, training, technique. Why are they getting this recurring discomfort? In other words, to achieve lasting effect, it is important that the target muscle is stretched once the tender and trigger points have been deactivated. So ladies and gents, when we're out there and we find a tender and trigger point, if we don't have time in clinic, we must make sure that our clients understand that they've got to stretch that muscle out. NMTs are considered to be a safe technique to use almost any time except in the acute phase following injury. NMTs cannot cause harm providing they're applied correctly and we use the necessary precautionary test. They are also an excellent diagnostic tool that can be easily integrated into general massage.